30, if we can get started here. All right, good morning, everyone. I'd like to call this meeting of the House Insurance Committee to order. The purpose of this meeting is to hear from experts on House Bill 305, which would establish a $35 cap on patient cost sharing for insulin. We'll have a brief question and answer period after each presenter's testimony. There are a lot of meetings in the Capitol today, and members are on as many as 5 or 6 committees, many of which meet at the same time. So members of the legislature will be coming in and out during the course of the meeting. Hopefully it won't be too disruptive, and just kind of a heads up to the presenters that folks will be coming and going. It's no, it's a good thing. It's no aspersion on anyone that folks get up and leave. So we will get started with the first testifier shortly, but first, Madam Chair, any comments or thoughts today?
Just thank you, Mr. Chairman, and I do thank the presenters for being here today, and I look forward to everyone's testimony. Thank you.
Thank you. So the prime sponsor of the bill, Chair Jean McNeill, is here. Chair, do you have any opening comments?
Good morning, Chairman Warren and Chairwoman Pickett and the members of the committee. Thank you for the opportunity to speak on this legislation. I have been working on this probably about 8 years, so I'm very grateful for the chance to have a hearing. In recent years, the price of insulin has tripled, forcing many people to choose between paying their bills and buying the medication they need to stay alive. We've seen the consequences: rationing, serious health complications, and even preventable deaths. No one should face that kind of choice. That's why I've introduced legislation to cap the cost of a 30-day supply of insulin at $35 for all Pennsylvanians. Insulin was meant to be accessible, not a source of financial hardship. We're following the lead of 25 other states, including New York, Maryland, Texas, and West Virginia, that have already set insulin caps. And while the Inflation Reduction Act capped costs for Medicare recipients, many working families and younger adults still struggle to find and afford this essential medication. I personally have a friend who has 3 grandchildren and a son, and it's a hardship for all of them to pay for the insulin. Our bill ensures that everyone, not just some, has equitable access to insulin. This is a straightforward, life-saving measure that will reduce medical emergencies, lower long-term health care costs, and protect the health and dignity of our residents. This legislation is essential so that no Pennsylvanian is forced to risk their health due to the price of a drug that's been around for more than a century. Thank you.
Thank you. We're also joined by our colleague, Representative Fleming, who is the co-chair of the Pennsylvania Diabetes Caucus. Representative Fleming, do you have any comments?
Thank you, Chairman, and thank you, Chairwoman Pickett, for agreeing to host this. I will keep my comments brief. I am incredibly supportive of Chair McNeill's legislation to cap insulin. As she mentioned, we did see this on the federal level with public health insurance with the Inflation Reduction Act, and unfortunately that was rolled back. If you haven't heard it by now, this is an extraordinarily personal story for me. My daughter, Emily, was diagnosed with type 1 diabetes at 7 years old on June 11th, 2020. That is her diaversary. We will never forget that day. She went in for a routine pediatric visit, and it was during COVID, so everyone was wearing masks. And she had lost 20 pounds in 6 months. She was skin and bones. And we thought, as her parents, we really didn't think anything was happening. When you're raising kids, they have this accordion effect where, they'll, plump up a little bit, then they'll stretch out as they have growth spurts and everything. So we just thought she was in a natural growth period. And it turns out her blood glucose was over 500 at the pediatrician's office. Her wonderful pediatrician, whom we will never forget, Dr. He, advised us to take her to Penn State Hershey Medical Center right away. And we went to the ER. She was diagnosed in very short order and put on insulin. The next day, this was a Thursday, the next day, Friday morning, right across the street is how they had it set up at the time. We went for diabetes education to learn how to manage her condition for the rest of her life. Again, she was diagnosed at 7 years old. And so, you know, as a 7-year-old, she couldn't handle it on her own. She's 13 now, and she's thriving. But we're also extraordinarily lucky as a family because we have health insurance, very good health insurance as a member of this General Assembly, and she doesn't have to worry about paying for her insulin at this point. Now, you know, we've seen effects to the ACA. The law is still in effect currently, which is great. So, which means that you know, under current law, and I hope it stays this way for a long time, I think one of the best provisions of the ACA was allowing children to stay on their parents' health insurance until the age of 26. And so we're still looking at another 13 years, perhaps, of her being covered under our health insurance, you know, assuming that her mother and I still have that. What happens then? You know, my daughter's life will be affected by this forever. She is insulin dependent, which means she will need to take insulin every day of her life in order to survive. And, you know, what happens to employment opportunities? She's going to have to have a job where she has access to health insurance. It's non-negotiable for her. And even though this is, you know, she's only 13 now, these are the things that I worry about at night, along with thousands of other Pennsylvanians, and you know, millions across the country, honestly, and across the world. And so that is why we are in such a critical moment here. And you know, some people who may not understand, you know, might be like, what's the big deal? Well, it is a life and death matter for those who are diabetic and can't produce insulin on their own. Without access to insulin, it will lead to serious health problems, eye problems, and even death. And so that's why this is such a critical matter. So again, I just want to thank the prime sponsor, Representative McNeill, and really thank you for illuminating this issue. Thank you to the advocates with you know, the American Diabetes Association, Breakthrough T1D, and I do have to thank the pharmaceutical companies as well, because, you know, we have engaged in conversation about this. They understand how pressing it is, and so we need to all work in tandem to make sure that insulin is affordable to each and every person who needs it. Thank you so much, Mr. Chair.
Thank you, Representative Fleming. And speaking of advocates, our first testifier is Colleen Wynn, who's a patient and advocate. And Colleen, if you'll come up and begin speaking when you're ready. Excuse me, Colleen, for just a minute. We've gotten word that maybe your speaker is not on. Is the green button illuminated?
Oh,
Okay, great.
sorry. So we aren't just buying one vial. We are buying 3, 4, 5 a month. When a single vial retails for hundreds of dollars, that sticker price you see in the headlines is actually tripled or quadrupled for the average patient. This is why rationing isn't just about poor people. It's about everyday working people as well. It's for teachers, the office managers, nurses who hit their deductible limit or find their prescribed brands of insulin have been dropped by their formulary. It's an outrageous financial burden that can hit working people like a sledgehammer. We often talk about insulin rationing in terms of the immediate emergencies. We think about those people who are ending up in the ICU in diabetic ketoacidosis, but then that's its own horror. But there's also like a quieter damage to this. When someone is taking 8 units instead of the 10 units they need because they are just trying to make it to Friday, that high blood sugar is having an effect on their body. High blood sugar is corrosive, and it's like pouring acid into your veins. Sorry. I've seen these results of slow rationing in my own community. I have lost friends to heart disease and kidney failure. People who didn't die because they ran out of insulin today, but because they've been rationing it for years. Many of my peers, people in their late 30s and 40s, are already losing their vision to retinopathy. They're losing their ability to walk. They are facing gastroparesis when their stomachs can't effectively function anymore. These aren't side effects of diabetes alone. These are side effects of a pricing model that prevents consistent, tight control of their disease. Because of the system is so volatile, I have become a hoarder. I consider myself lucky because I have a small stockpile of insulin in my fridge. Think about how dark that is, that I feel lucky to have a surplus of a hormone that I require to breathe. But my fridge doesn't just serve me, it has also served my friends and neighbors. On more than one occasion, I have had to meet people in parking lots, complete strangers, to hand over life-saving medication. The most heart-wrenching among them are domestic violence victims. When a woman leaves an abusive situation, she often leaves with nothing but the clothes on her back. Her insurance is often tied to her abuser's employer, and her prescriptions are at a pharmacy she can no longer safely visit. I have stood in these parking lots handing over vials, knowing that if I weren't there, that the person could end up in the ICU in a matter of days. I am not a medical distributor. The fact that I have to do this is a searing indictment on the current landscape of insulin in Pennsylvania. On top of insulin, there is so much more financial burden to diabetes. CGM sensors and testing supplies, which can cost hundreds of dollars a month and are necessary to know how much insulin to safely use. Insulin pumps and supplies to safely take the insulin. Glucagon, which is a life-saving medication when your blood sugar drops dangerously low. And of course, doctor's visits, endocrinologists, primary care doctors, eye doctors, all of those copays really add up. We are paying thousands of dollars a year just to stay at the baseline of a healthy person. When insulin prices are allowed to skyrocket, it collapses the entire house of cards. I have lived with this since 1989. I am tired of seeing my friends die or go blind because of a corporate bottom line. I am tired of wondering if the person I meet in a parking lot tomorrow will be the last one I'm able to help. I urge this committee to pass meaningful insulin cost capping legislation. Do not let luck be the determining factor in whether a Pennsylvanian survives the night. Thank you.
Thank you. So what's the current range of out-of-pocket costs that you've experienced for insulin?
A single vial of insulin can be $400 about. Out of pocket and insurance, it's a little tricky. I actually work for the house too, so I have the same insurance you do, but before I worked here, I was paying probably $60 a month for insulin, and that's lucky.
Thank you.
I have no further questions, but that was an interesting answer for me, too. Thank you.
Thank you.
Thank you. Do any members, Representative Menser?
Thank you, Chair Warren. I just have a quick question here. What's the shelf life of insulin?
It can last. It depends on there's an expiration date on the vial. So, but once you open it, it's 30 days. So, it usually doesn't last that long. either.
Questions from other members? Representative Flood.
Good morning. Thank you for your testimony, and
Thank you.
I apologize for being a little late.
No, it's okay.
What happens? You were talking about keeping the insulin in your refrigerator, and for a person who uses it all the time, like what happens if you break a vial? Can you get that replaced?
No.
So insurance won't cover the cost of a replacement.
No, and that's a real problem for, like, I've seen that happen to people where they can't get a replacement and have to reach out to the community to get a new one.
Are there, and again, I came in a little late. Are there any legal issues with sharing?
I'm sure there are, and
Yeah.
I mean, I personally haven't seen it, but you know, there used to be a lot of like patient caring sharing groups on Facebook and that sort of thing, and that's kind of gone away because of people getting into some legal trouble. So.
And and I know you're talking about yourself, but I imagine there's probably other people that do similar things with sharing the insulin. What are the risks, right? Is the chance of contamination?
No, as long as it's not an open vial, not really. Not at all.
Okay.
Yeah.
All right. All right, great.
Yeah,
Thanks.
sure.
Thank you. Any further questions? Lynn?
Thank you.
Dr. Rao. So our next testifier is Dr. A.J.D. Rao, Chief of Section in Endocrinology, Diabetes, and Metabolism, and Associate Professor of Medicine at Lewis Katz School of Medicine at Temple University. Doctor, please begin your testimony when you're ready.
Can you all hear me okay? Thank you, Chairman Warren and Chairwoman Pickett and the members of the committee here. I really appreciate the time to speak to you all today. My name is Ajay Rao. I'm a practicing adult endocrinologist in North Philadelphia, where I care for a large population of persons living with type 1 and type 2 diabetes. So this issue is very near and dear to me. I'll deal with it on a daily basis. As mentioned before, I'm the Section Chief of Endocrinology, Diabetes, and Metabolism at the Katz School of Medicine at Temple University. Access to insulin is one of the most critical things that I face when I'm taking care of patients living with diabetes. And my chance to offer perspective is really crucial, I think, for where things are going to go here in the Commonwealth. My comments today are going to focus on 4 areas: how insulin affordability currently plays out in my practice, tiering and copay systems, and how that affects day-to-day diabetes care, and you've heard some comments about this already. The barriers that my patients in North Philadelphia face when they are trying to obtain insulin, and really how other states' experiences should inform our policy decisions. So as an endocrinologist, I specialize in taking care of probably some of the most complex of persons living with diabetes. Not only adults with type 1 diabetes, where they cannot survive without insulin, but also we have to recognize that there's a good deal of people living with type 2 diabetes who need complex regimens that actually include insulin also. Patients who might have pancreatic damage to their ability to make insulin from inflammation to their pancreas, or particular conditions like cystic fibrosis, and this leads to a particular type of diabetes that is almost effectively like type 1 diabetes. They need insulin. For many of these patients, insulin is not optional. It is a daily, life-sustaining medication for them. We see a wide fluctuations in the out-of-pocket costs. Some plans cover commonly used long-acting insulins and short-acting insulins at a reasonable tier, while others impose these high copays. When I speak to patients, it seems like every time it's a different price. Even the most clinically stable patients may suddenly learn in January of every year that the insulin that they've used safely has been moved to a higher tier or replaced with a non-preferred option. And so the medical consequences of these shifts are significant. Insulin is not a medication we can easily switch without risk, and it comes with a lot of downstream issues in the care of patients, and a lot of burden to not only the patients, their family members, but also the clinicians taking care of them. Tiering and copay cards. Insulin tiering is really complex. Patient may have coverage, but that often comes with this copay that's really essentially functionally prohibitive. Some of the pharmaceutical companies have copay cards that might help relax the out-of-pocket costs for the patient, but that can only be used by those who have commercial insurance. Folks who are on Medicare or Medicaid who make up a large portion of those living with diabetes cannot use those copay cards. So even though for some commercial patients that can help them in the short term, it doesn't really help the bulk of our patients. There's also barriers, what patients face when it comes to accessing insulin. This, again, as I mentioned, the high and unpredictable monthly out-of-pocket cost, yearly formulary changes on what is the brand, delays in prior authorization processes, and then costs, as was alluded before, associated not only with insulin, but the things paired up with them. For example, automated insulin delivery devices, what we call insulin pumps, continuous glucose monitors to sense their sugars and be able to make accurate decisions. And I think the one thing that is the most important thing that I feel always sad that I don't ask about this enough with my patients is that rationing occurs. It is happening all the time. When I ask my patients, sometimes I don't want to ask my patients, I should be. When I ask them, why are you running out or what's going on here, you start realizing they are rationing. They are rationing the doses. When they're rationing the doses, their care is compromised. This leads to poor outpatient care. This leads to repeated hospitalizations, readmissions, big burden to them. So, clearly we've seen other states in this country who have gone forward with insulin cost caps, and that can range between a variety of numbers. Some of this actually includes diabetic supplies, although I know that's not a specific topic of this committee. But I hope you all can understand the importance of this on a day-to-day situation for a patient living with diabetes. So in closing, I hope you all see how essential, consistent, affordable access to insulin is for our patients' health and safety. The out-of-pocket cost remains one of the most significant determinants of adherence. A predictable, manageable monthly cost cap, such as the one proposed here, can prevent dangerous rationing, reduce medical emergencies, and support better long-term health outcomes. Thanks again for the opportunity to share my clinical experience and perspective. I'm happy to answer any questions.
Dr. Rao, would you explain what commercially produced insulin is? Is it distinct from the insulin that's
No, it's the same. I think you're asking about commercial insurances and what insulin they get versus others. No, it's the same. It's the same. It's just that perhaps for those who have commercial insurance, they are allowed to use these copay cards that the manufacturers.
So my question was actually to the product itself. Is it distinct from the insulin that the body produces, or is it an identical?
Oh, I see what you're saying. So the insulin all of the insulins that are available on the market are what we call recombinant insulins. So they're all variety of interchanges in their amino acid structure to allow them to be given as injections in a variety of ways, whether it's long-acting insulin or short-acting insulin. And that's been what we've been doing for at least 20 to 30 years. Initially, when insulin was discovered, it was human insulin that we were giving to individuals. But now, more recently, in the last 20 to 30 years, these usually recombinant insulin made by pharmaceutical companies.
Thank you.
Question of more or less curiosity, but Doctor, I wonder if you have a thought or an opinion on this. It seems to me that we're talking today about controlling the copay. That's one subject, but this product has been around for a long time. It's a very common product. Why is it escalating in the marketplace like it is? We can hold this copay, but that's not going to do anything to the cost of the drug, and that affects everybody's insurance and the entire healthcare system. Do you have a thought on why that is happening with these companies?
The companies are, have boards to answer to. They are, I think they're quite transparent that they are, they're looking to make money. I don't think there's anything that's convoluted about that. I think they recognize that there's a lot of individuals living with diabetes in this country and worldwide. So I think there is a market for them, and hence I think that is something that they focus on. I would additionally add, luckily we are seeing the beginnings of what we call biosimilars and bioidenticals into the market, which means that company B can make the sauce of company A, and that's no longer sort of stealing after a certain patent has expired. So I think we're hoping that the thought has been that that will lead to some reduction in that overall milieu that you're alluding to.
So that in effect leads to competition. You did mention also that if their product escalates, and then therefore affects their copay perhaps, and they want to switch to another product, they have to go back through a prior authorization. Is that quick? Is it a problem? How does that go?
Prior authorizations definitely take time. Sometimes on the same formulary, they might be a different brand that will be covered. However, out-of-pocket cost is not capped currently, so that that could still be a high cost, out-of-pocket cost. But if there's a brand that a certain patient wants to continue on, and in January the formulary is changed, there might be a need for that sort of prior authorization, and that does definitely take time.
Thank you for that insight.
Questions from members? Representative Flood.
Good morning. Thank you for your testimony. A lot of people who have type 2 diabetes that require insulin, are they also taking other medications like the GLP-1s? Because we all know about them now. We know that Mounjaro in particular has been shown to really be able to help control the levels of insulin in people who are diabetic. And now, it's not just the shot, they have patches, they have pills, other things. And is that going to help alleviate some of the pressure on insulin usage if you are able to, control your levels through GLP-1s?
Yeah, I think your last statement is the biggest one there. If you're able to control with the existing treatments that are not insulin. For those living with type 2 diabetes, the idea is that we believe their body is making insulin still. However, we don't really know if it's enough or if it's a good quality to be doing its job with sugar lowering. People living with diabetes, their number one risk of death is heart disease. And in individuals who are living with type 2 diabetes, anybody in diabetes, we're approaching things twofold. One is sugar lowering to prevent them from having the sort of standard complications you all have heard about, the eyes, the feet, and the kidney. But also we are concerned about heart disease. So some of these newer agents, as you've mentioned, have shown benefit for preventing of heart disease in addition to their glucose lowering benefit. But we do still know that there are many people with type 2 diabetes who in the end will still need insulin treatment. So I think you are correct that if we can hopefully prevent the sort of commingling pandemic or epidemic of overweight obesity amongst the people living with type 2 diabetes, perhaps insulin use in 2090 will not be as much as in 2026, but that requires a lot of efforts in multiple ways. But many people living with type 2 diabetes still require insulin for a variety of reasons.
So maybe coupling both of them together can really help.
Absolutely.
So, and I know we're talking about prior authorizations for insulin, but there's also an issue with that with the GLP-1s.
Yes.
So that's also another hurdle that has to get over, at least so we can have a level, making sure that people are having level, how do I want to say it? Just consistency with their medications.
Yeah, I would say it's early part of February now. The Commonwealth has made a decision on GLP-1 coverage for the anti-obesity indication, which is for the weight loss indication, and that has been very painful for me, and more importantly, for the patients living with overweight obesity, where perhaps we could prevent downstream events like diabetes if they're able to be exposed to those things.
Great. Thank you.
Yeah.
Other questions from our members? So, following up on Representative Flood's question, So is the GLP-1 like a preferable treatment or to insulin? Or do you try GLP-1s first before going to insulin, or are they separate tracks depending on the
Amongst
nature of the
people
diabetes?
living with type 2 diabetes, the standard of care is usually dependent on what their prevailing 3-month control level is upon that first visit. So, which is known as the hemoglobin A1C, or if they're having symptoms of an elevated blood sugar, hospitalization, urinating a lot, thirsty a lot, weight loss, that sort of thing. Again, I'm speaking about type 2 diabetes here specifically. For those individuals, depending on where their A1C is at baseline, you're absolutely right. We probably would move first towards non-insulin therapies. But there are many people who come into hospitals with new onset diabetes, come into clinics with new onset diabetes, where their A1Cs are so high that the initial treatment will be some form of insulin for many of them, with the hope that we will eventually get them off of insulin in the long run. Again, that's those with type 2 diabetes, not for those who have type 1 diabetes.
Okay, thank you. Any follow-up questions from anyone on the panel? Thank you, Doctor. Monica, Bilger or Bilger? Bilger. Thank you. So our next testifier is Monica Bilger, Director of State Government Affairs, Mid-Atlantic, and member of the American Diabetes Association. Thank you for joining us.
Thank you, Chair Warren, Chair Pickett, and distinguished members of the committee. My name is Monica Bilger, and I'm the Director of State Government Affairs for the American Diabetes Association, and we are in strong support of House Bill 305 to make insulin more affordable for Pennsylvanians who need it. The trends tell us something is not working. Prevalence of certain health outcomes like diabetes and obesity have worsened over the past decade, and rates of these intersecting diseases continue to rise. A rising diabetes epidemic means we must address our insulin affordability crisis. The cost of managing diabetes can be unsustainable to individuals living with diabetes, but also to the Commonwealth. People with diabetes have medical expenses 2.3 times higher than those who do not. That holds true here in Pennsylvania, where respondents to ADA's 2025 Access and Affordability Survey reported medications as their top medical cost and #1 reported barrier to staying healthy. More than half the households surveyed reported spending over $200 a month on diabetes care. Insulin is an essential chronic disease management medicine, critical for Americans living with type 1 diabetes and some living with type 2. Unfortunately, you would likely know someone who may have rationed their medication due to economic struggles, as 1 in 6 have reported needing to ration their insulin, in line with ADA's 2025 affordability survey, where 1 in 5 Pennsylvanians reported rationing, delaying, or skipping insulin to afford expenses like food, gas, or rent. Empowering people to effectively manage their diabetes by lowering cost share burdens will allow people to better manage their glucose levels to stay healthy and productive. And when people, as you've heard, with diabetes are unable to manage their disease and access the insulin they need, it increases the risk of developing costly and burdensome complications, including diabetic ketoacidosis, increased risk for infections, increased emergency room visits, which is an issue that's being studied now in Pennsylvania, and extended hospital stays. And over a long period of time, insulin rationing can lead, as you've heard, heart disease, kidney failure, amputations, and even blindness. Evidence suggests that copay reductions do improve medication adherence, which in turn reduce, delay, or prevent the risk of these costly diabetes complications. In 2020, Blue Cross Blue Shield of Louisiana created a study to look at medical adherence, so they put forward a zero cost share for people who are living with type 2 diabetes. What they found was that per member per month, there was a decrease in cost of over $100. And for those that were dealing with type 2 diabetes plus other complex situations, that number was even higher in cost savings. We are very thankful that manufacturer rebates and copayment assistance programs have helped ease some of the burden, but not all insulins, as you've heard, are covered. And copay assistance programs have variable eligibility requirements and reduced out-of-pocket payments to variable degrees. With today's economic volatility and the importance of person-centered disease management, we warrant a stable solution for those that need access to life-saving medication. It's also why 29 states now and the District of Columbia have passed caps on out-of-pocket costs for insulin. Actually, 4 have also passed out-of-pocket caps on equipment and supplies as well. I finally want to commend the Joint State Government Commission Biennial Diabetes in Pennsylvania report. We have 2 writers here today. A thoughtful and thorough review of the current state of diabetes here in the Commonwealth. The report has been recommending to the General Assembly to pass legislation that caps patient out-of-pocket costs for insulin in the past 3 reports, starting in 2021, 2023, and 2025. It actually also referenced taking steps to improve insulin affordability in 2019, and as early as 2018, made a recommendation to make diabetes drugs and testing supplies free of charge. With diabetes diagnosis increasing and costs of treatment continuing to rise, we must provide preventable measures and make life-saving medications more affordable. Thank you so much for your consideration. I'm happy to answer questions. I should note one of the biggest questions we get is oftentimes about premiums. We have not seen since the implementation of these costs in 2020, in the 29 states that so far have these cost shares, any real increase in premiums. They've been negligible, and so we really want to just do away with that argument right away. So thank you so much for your time.
Thank you. Chair Pickett?
In your testimony, you used the term insulin affordability crisis. What do you think is some of the top contributors to such a situation as that?
You know, I wish I could better speak to that. There are so many layers as to what that could mean for so many people, from social determinants of health issues on insurance, underinsurance, just, you know, there's so many layers. The American Diabetes Association's primary focus is to how to make it more affordable for people and what we can do. And so that's why we're here today, continuing to share the message, continuing to share studies that showcase medical adherence improves when people are able to access the medications they need, when they're able to access the technologies and for their diabetes management. And that's really what we just want to make sure we're sharing. But agree, there's just many layers as to the why.
Thank you. Do you see in general that people that have insurance are paying $35 or less right now?
It varies. Again, even with our study, people who are insured are still struggling to pay. So it really varies from individual, from the type of insurance they have and so forth, which is why to have a more stable consensus wrapped around a one price point for everyone would be just an easier way instead of having the volatility and variability. You think also sometimes people leave a job, that impacts what they can do and how they can afford their insulin, even if they have the insurance. So it's really critical to just try to create a baseline so that everyone can access that affordability.
Okay, and so are you able to say what, in general, somebody without insurance might end up paying out of pocket?
I think the individual that spoke earlier spoke to that. It can vary. Without insurance, you know, you could also potentially get some of these rebates or manufacturer coupons, so it's hard to say where someone might come in. But we've had individuals, patients, who have spoken to costs of up to $1,200 a month. You can understand that could be potentially unsustainable. And when I say $1,200 per month, that's multiple vials, right? But I think that, again, we know individuals who are paying $6 per month. So it's just very varied, and it's hard to say that there is an average cost for any one individual when the landscape is just so varied.
Thank you. It requires a lot of research on the part of the patient, I guess. Thank you.
Thank you. Members, questions? Representative Sappi.
As a rule, I prefer to save the questions for my colleagues who are medical professionals, but
I am not one.
okay, yeah. So forgive my ignorance here. I know that we've experienced an increase in, obesity and diabetes over the last several years, but are we seeing this growing faster in children or adults or both? And what is the cost implication in either of those demographics?
It's certainly for both. We've seen an uptick. You have children with type 2 diabetes now being diagnosed as young as 9, 10, 11 years old. And, so it is a growing epidemic on both fronts, and we are very much in favor of preventative care in the space of obesity to delay the onset of something as disastrous as type 2. But obesity also accounts for 200 other diseases. It's not just diabetes. So, the costs of inaction around obesity are, insurmountable. So we are seeing massive upticks. The trend, as I've mentioned earlier, is going in the wrong direction. What we're doing right now is not working. Prevention, access to affordable medication, access to affordable treatment is critical because that allows individuals to be empowered to adhere to their management plans and ultimately improve their outcomes and avoid costly complications and emergency room visits and so forth.
Thank you. Further questions?
Thank you.
Thank you. Michelle? Our next testifier is Michelle Crimmins of Prime Therapeutics.
That's me.
Great. And did I pronounce your name right? Or correct it if I didn't? Thank you.
Thank you very much. Thank you, Chair Warren and Chair Pickett. I appreciate this opportunity to speak in front of the committee today. I've submitted my testimony in advance, so you each should have an electronic copy of that. And instead of repeating what I've already submitted, I'd like to instead provide supplemental comments to that. So my testimony today is in opposition to the bill, and it's not because I disagree with those that have testified before me. I actually found a lot of their testimony to be rather compelling. It's because I don't think this bill is going to solve the underlying issues that they raised. When we did a review of our claims for 2025, all of the claims processed by Prime Therapeutics, which is a pharmacy benefits manager, we found that more than 90% of the claims had members paying $35 or less per month for their insulin. Now, the number of members paid more than $35 per month includes members that paid more by 8 cents, right? So that's included in that 10% remaining. I did also look to see in the number of members that are paying more than $35, which ones are significantly paying more. So I looked at the number of members that are paying more than $100 per month out of pocket. And I found that there are actually 15 members that had claims for a drug called Afrezza. And that was during 2025, and 11 of those 15 members paid more than $35 a month. And that amount out of pocket for the member went up to about $280 out of pocket per month. So we're talking about a small percentage of the claims that have been adjudicated, but I do recognize that's an impactful number. So why is that drug so expensive? Which was the question I had, right? It's actually very new to the market, very specialized, inhaled version of insulin, which I think we can all agree would be probably very convenient if you have to take insulin to inhale it versus inject it. It is designed to be rapid acting. It's designed to be inhaled at the beginning of meals to control high blood sugar, and it must be used with long-acting insulin in type 1 diabetes. So why would this drug be more expensive than many of the other drugs that are on the market? It's because it's new. There's no competition. And that raises one of the biggest issues with the cost of drugs across the board, not just insulin. When a new drug comes to market, they have an exclusivity period where you cannot have competition come to the market. And I provided a handout to all committee members previously that shows a report that shows it's on average 16 to 17 years that exclusivity period could be. So that would be the time on the market before there's competition where we would expect for that price to go down. And for Afrezza, that would mean that we would expect a biosimilar to come to market in about 2030. That's when we would expect the competition to bring the list price of the medication down. So in conclusion, You know, my opposition to the bill is not because I disagree that there could be an insulin crisis or that it is challenging for some people to afford insulin, but this bill does not address the uninsured. This bill does not address the high list prices of drugs. And this bill would cap insulin copay prices for a very small number of consumers while not addressing the larger number of uninsured or those using high-cost medications. And I welcome any questions, and if anyone would like to have a conversation with me after the hearing, I'm also open for that. Thank you.
Are you able to comment on the federal cap going on insulin going into effect? Did you see increases in the list price on the product at that point? If so, how much?
I'm not familiar if there were list price increases on that. I can say financially impacted plans. Most plans prior to that have voluntarily made that price be $35 or less per month.
Chairman Mentor?
Thank you, Chairman Warren. My question is about this new product that is an inhalable insulin. Would the traditional product do the same thing but be a little bit more inconvenient?
I'd love to answer that, but unfortunately I'm not a doctor or pharmacist, so that would be better directed to one of them. My understanding is there's potentially comparable products that have a different administration, but whether it's the same for the patient, I'm not sure.
Okay, thank you.
Representative Nelson?
Thank you, Mr. Chair. And I appreciate, your coming and testifying today as a PBM. I thought it was interesting when you talk about biggest issues and underlying issues, because I would suggest almost as a PBM, you are one of the contributing factors to excessive cost and, creating considerable difficulties in the market as it lies. As a PBM, are you currently doing gap pricing on insulin products? Because we're aware, and I disagree with the practice, but it's not currently illegal, that you're allowed to pay for one thing, raise that rate, reimburse at another, and keep that profit difference. Are you doing gap pricing for insulin products?
For spread pricing,
spread pricing.
So spread pricing is actually a contractual agreement between a plan sponsor and a PBM, so it's not on an individual product. It would be a risk mitigating product that is agreed upon at the time of contracting that sets a guaranteed rate across the board for all of the pharmacy claims for the plan sponsor. So that would be a business, a government, those entities. And then if the PBM is able to negotiate a better rate, that would be the reimbursement for the PBM services. There's a lot of times PBMs actually lose money, and I can confirm that Prime Therapeutics does lose money on some claims with spread pricing.
So if I'm hearing you, there's potentially you do have spread pricing going on with insulin-related products in your contracts with medical providers or insurance companies in dealing with people in Pennsylvania.
Again, the contract would be
because your
with
contract
the plan
could have
sponsor,
spread
and it's
pricing
possible.
layered in.
It's possible that a plan sponsor that has chosen spread pricing could have a member that's using insulin, if that's your question.
Yeah, so then your answer is yes, it is possible that you are doing spread pricing, which is causing those rates to increase because of additional profits for your PBM.
I disagree with that last statement.
Thank you, Mr. Chair.
Thank you. Any further questions? Thank you.
Thank you very much.
So, Megan? Megan? Yep, there you are. Our next testifiers are Jonathan Greer and Megan Barber of the Insurance Federation of Pennsylvania. Thank you.
Good morning, Chair Warren, Chair Pickett, and members of the committee. Thank you for the opportunity to speak with you today on House Bill 305. My name is Megan Barber, and I'm the Executive Director of the Insurance Federation of Pennsylvania. We are a multi-line state trade association representing commercial health insurers across the Commonwealth. And as my colleague spoke before, I do want to start with just making it very clear that we do fully share your commitment to making insulin affordable. And we agree that action on prescription drug prices is not only warranted, but it is also essential. However, as written, we believe that House Bill 305 does pose significant risks to insurance affordability, market stability, as well as the long-term prescription drug costs in Pennsylvania. And today in my testimony, I'll get into why that is. So first and foremost, this bill focuses on capping out-of-pocket costs for consumers, but does nothing to actually regulate the list price of insulin. And because cost sharing is capped at $35 across the board, manufacturers themselves remain entirely free to raise the price without facing the usual market pushback that they would. And as a result, the full financial impact of rising list prices would fall squarely on insurers, which could then trickle down to consumers through things like higher premiums, higher deductibles, and higher cost sharing in other benefit areas. So there are things other than premiums that we need to be looking at as well. And this is just the predictable economic result of having insurers absorb unlimited manufacturer prices without being able to control costs on their own end. This bill, by making that cap universal, also eliminates one of the most effective tools that insurers have to negotiate lower drug prices, and that is through eliminating tiered cost sharing. That practice helps consumers choose lower cost medications and pressures manufacturers to keep their overall costs down and to keep their products competitively priced. Without the ability to differentiate between these products, consumers lose the price signals that help steer them towards more affordable options. And insurers lose the leverage needed to push manufacturers toward lower prices. Manufacturers then, in turn, gain more freedom to increase the list prices because those list prices and those hikes won't affect what their patients pay at the pharmacy counter. Over time, insurers may be paying more for insulin than they could recover in premiums without raising those rates. And this dynamic puts upward pressure on premiums across the board. We'll see this effect through things like employer plans will experience higher costs. The individual market will face higher premiums as they are already. Small businesses that offer health insurance will experience greater financial strain. And some plans may look to scale back on other benefit richness areas or reduce the number of products that they offer. And ultimately, Pennsylvanians, even those who do not use insulin, could end up paying more. And these consequences come at a time when healthcare is already at a point of an affordability crisis. And we have testified in other hearings to this effect as well. This year, Pennsylvania Insurance Department approved average rate increases of 19% in the individual market and 13% in the small group market. Rising healthcare costs, increased utilization, and the expiration of the enhanced premium tax credits have led some consumers to face premium increases of more than 100%. And in Pennsylvania, we have seen individuals who are closing in on 500% premium increases. So if health insurance itself is continuing to be unaffordable, the cause is not the design of the coverage, it's the underlying cost of care, and that's where we need to be focusing. Our member companies, many of them already provide insulin at no cost to patients under preferred drug programs, and others offer most insulin products below the $35 threshold for the 30-day supply. However, this bill would prevent insurers from distinguishing between preferred and non-preferred products because it removes the ability to use tiered pricing strategies that encourage the lower cost care options and help keep overall premiums down. And so again, we do share in the goal to make insulin truly affordable, and therefore we propose that this committee look at targeting the root cause, which is the list price of insulin itself. And there are several alternatives that we can mention, and that includes adopting stronger manufacturer transparency laws, imposing caps on insulin list prices rather than patient cost sharing, restricting excessive annual price increases, creating bulk purchasing programs, and encouraging greater use of biosimilar insulin products. These approaches go directly to the cause of high prices instead of shifting the financial burden onto the insurers and then ultimately the policy holders. I want to end by saying that we do fully understand and respect the intent behind this bill. The desire to ease the financial strain on patients is commendable and shared by all of us. However, as written, the bill would unintentionally give manufacturers greater pricing power, raise premiums for Pennsylvanians at a time when affordability overall is already strained, and do nothing to actually address the list price of insulin. So for these reasons, we do respectfully urge the committee to oppose this bill in its current form and instead look to pursue comprehensive reforms that tackle insulin at their source. Thank you for your consideration, and I'm happy to take any questions.
Okay, thank you. Chair Pickett?
No questions, but I do want to thank you for offering the other recommendations that we may look at regarding the list price. I do recognize that as certainly the underlying issue that we have to deal with here. And probably should talk further about the possibilities of being able to do something on that level and not make the whole market suffer from what we do. Okay,
We would be happy to, and thank you, Chairwoman.
Questions from other members? Oh, well, thank you, Ms. Barber, and thank you to all our testifiers for sharing their expertise and insights with us today. We'll take it all to heart, and as this legislation proceeds through the consideration process. Last week, we announced Executive Director Alan Cohn's retirement. Today, we're also saying goodbye to our Senior Research Analyst, Joe Keller, who will be joining the Office of General Counsel in the Shapiro administration at the end of the month. So thank you for all your work over the years that we've worked together here on the committee, and we wish you the best.
Oh, my goodness, Mr. Chair.
yeah, that's what I said.
That's what you said. I'm sure you did. Well, congratulations to both of you. I assume we have your phone numbers and you're on call. Thank you.
Any closing comments beyond that, Madam Chair?
That's where we have to end that one, yeah.
Thank you. There being no further business, the meeting is adjourned.